Hello, my name is Dr. Marysia Tweet. I'm a cardiologist at Mayo Clinic in Rochester, Minnesota, and I'm hosting today's interview with the experts prevention segment, Cardio-Obstetrics Topic 3, called Pregnancy, Labor and Delivery, and Postpartum Care in Women with Cardiovascular Disease. And today I have three esteemed guests joining me. I have Dr. Katie Young and Dr. Carl Rose, who were present for our topics 1 and 2. Dr. Young is a board-certified cardiologist at Mayo Clinic in Rochester, Minnesota, and she's the director of our cardio-obstetrics clinic. And Dr. Carl Rose is a professor of maternal fetal medicine and also works very closely with the pregnancy heart team at Mayo Clinic in Rochester. We also have a new or additional guest. Dr. Katie Arendt is the professor of anesthesiology in the Department of Anesthesiology and Perioperative Medicine at Mayo Clinic in Rochester, Minnesota. And she has expertise in obstetric anesthesiology. So we're very excited for her to be here with us. She did an extra fellowship at the Brigham and Women's Hospital on this topic, and she has research interests on obstetric anesthesia management, has written on the topic, has performed novel original research, has participated in guidelines, and is often invited as a speaker. So I am very excited to have her here today. And all three of these individuals are individuals that actively participate on our pregnancy heart team for patients that we care for here in Rochester, Minnesota. And I just can't wait to get started. So perhaps to start, Dr. Arendt, I think because you're new to the discussion for this topic number 3, can you go a little further into the role of an obstetric anesthesiologist and what that means both for the pregnancy heart team and the work that you do for women with heart disease?
Sure. Thanks, Marisha. So anesthesiologists in general are physicians who are trained to keep people safe and comfortable around the time of procedures or surgeries. And so we like to say we're perioperative physicians, but for labor and delivery, we're peri-delivery physicians. And so we really work, hopefully at the right hand, not the left, if you're right-handed, right, of our obstetricians to help do a couple things. And one of the main roles that we have is to keep mothers safe. And so typically, even though it's not what we do most commonly, probably our most important work is in resuscitation from shock. So if a woman goes into shock while she's delivering a baby, the obstetrician needs to fix whatever problem, or the cardiologist, it's called, they need to fix whatever problem, and we need to keep them alive in the meantime. And so that is the most important work that we probably do. The second most important work, besides keeping mothers safe, is keeping newborns safe. And what that typically means is that if a baby during the labor process begins to not necessarily look as healthy, we need to provide surgical conditions to our obstetrician as rapidly as possible for that baby to be able to be delivered. And that is actually probably some of our most tense and difficult work, is to get that done quickly and safely. But the work that we do most often is to keep mothers satisfied through this birth experience. So if they're having an urgent or an elective cesarean delivery, essentially we want to keep them safe, satisfied, and comfortable. Typically that's with spinal anesthesia, but occasionally general anesthesia as well. And if they're in labor, if a woman so chooses that she wants epidural labor analgesia, we provide that for her. So that's our work as an OB anesthesiologist on the labor and delivery floor. For women with cardiovascular disease, it's really in that number 1 that we need to be ready for. So we need to be ready to keep these patients safe on our labor and delivery floor, which means, if they go into shock from an obstetric cause, it can quickly deteriorate into a cardiovascular emergency as well, or they could have a cardiovascular emergency that quickly becomes an obstetric emergency. And so really being thoughtful, making sure that we're helping to risk stratify, or at least listening well to your risk stratification, and then deciding what kind of monitoring we want in order to respond quickly, and then how we get ourselves quickly out of a tricky situation, which can happen quite quickly for patients with cardiovascular disease. So as they begin to get hypotensive or tachycardic, what do we give? What does that look like? How do we sort of get ourselves back stable again?
Excellent. And I'll ask Dr. Rose and Dr. Young to weigh in a moment, but From your perspective, thinking about these patients that we're caring for throughout their pregnancy, when is the best timing to loop you into the pregnancy heart team and have you be part of the discussions? And then Dr. Rose and Dr. Young, I'd also like your input on that too.
What we ask for is for Dr. Rose's team to go ahead and consult us. Typically, we start getting looped in during second trimester. However, there are scenarios where we want to be looped in if there has to be a termination of pregnancy, whether that's a pregnancy loss and so on for these patients. Because if termination needs to happen or a missed abortion for a patient that we need to do a procedure on in order to help keep them safe, they typically that should not happen outside of an operating room. And for very, very sick patients, especially patients like with Eisenmenger syndrome, or because this really maybe even should happen in a cardiovascular operating room. So I would say whenever there needs to be a procedure, whether that's first or second trimester, and then probably end of first or second trimester is when we like to be looped in to begin that delivery planning. But I'll defer to them as well. So yeah.
I would echo my colleague Dr. Arendt's thoughts. And I might add to that, I think we stratify on an individual basis depending upon each patient's sort of cardiovascular situation. If we have someone who is a little bit more hemodynamically tentative, might be the way to put it. In those situations, we might have that patient meet with our anesthesiology colleagues earlier in the pregnancy, perhaps 24 to 28 weeks, versus if it is a more routine, simply peripartum planning, but mom is completely stable, perhaps in that situation, 32, 34 weeks.
So I agree with everything. And, we all work together and see many of these patients together. And I think for the vast majority of patients that I see from a cardiology standpoint, I want all of them to see anesthesiology before the delivery. And so here at Mayo, typically, as Dr. Arendt and Dr. Rose said, it's around 28, 30 weeks. That's kind of a big time point when women are coming back to see cardiology, MFM, and then that's usually the time where we have them see OB anesthesia as well. We also include OB anesthesia and their fellows and their trainees in our monthly discussions about these patients. So that we welcome input and discussion on these patients when things come up during the pregnancy, like arrhythmias, when there's concerns about someone with an unstable aorta or, any of these things, really, we immediately go and pull in our colleagues. So certainly it can be at any point during the pregnancy, but most commonly that 28 to 30 weeks. And I think from a cardiology standpoint, what I try and do is obviously outline very well kind of the main cardiology problems or what I think may cause the mom and baby issues during delivery, and really try and outline in my notes what I think the mom is at most risk for. Are we really worried about arrhythmias? Are we really worried about, atrial or ventricular arrhythmias? Are we worried about them becoming unstable from the volume and fluid? Do we need to be careful about fluid administration? And then, or is it someone with HOCM who has an obstruction and we need to be, wondering and careful about preload and afterload? And so I just try and really outline in my notes kind of the main worries I have or things so that, because I think that, and Dr. Wright, you can chime in, but I think that helps anesthesia then when they're seeing the patients make a plan for their colleagues and themselves when the patient eventually comes in during delivery.
Yeah, Katie, I can think of a couple times where I've actually called you and been like, I need you over here because the patient's actually has, arrived, usually by ambulance, and they are in heart failure. And we don't know why they're in heart failure. And that's what you're there for. And so you come on over. And in the meantime, I know that any woman that's pregnant, it's kind of like it's a ticking clock to when they're going to need a surgical intervention, right? It could happen very, very quickly that suddenly I've got to provide anesthesia. And if I don't know the hemodynamics that we're working with, when we go to provide the anesthesia for a cesarean, Dr. Tweet, there's huge hemodynamic kind of effects that happen, whether we do a spinal, an epidural, a general anesthetic. And so if we don't know what we're working with, it's really hard for us to maintain hemodynamic stability. If we know what we're working with, not a problem at all. And so that's why it's kind of like, is this, what is this a patient have, decreased systolic function? Does this patient have some sort of, aortic stenosis or mitral stenosis? Or is this patient hyperdynamic? There's so many different options of when patients suddenly start putting fluid into their lungs. But I think that's one of the emergencies. I think I worked with you last, Katie. So thank you for all your help.
So you brought up, there's two things that I wanted to talk a little further about. Dr. Young, you mentioned the monthly meetings with members of the pregnancy heart team. I'd like to hear a little more about what that is and how that might help with the coordination of care. Dr. Arendt, you mentioned that sometimes in these emergent settings, you're just calling your colleagues on the moment and getting the help you need for that patient. There's a lot of unexpected events, with delivery. But after we hear a little more from you, Dr. Young, about kind of these monthly meetings and what they entail, I would like to have you, Dr. Arendt, Dr. Rose, and Dr. Young as well, kind of go a little further about delivery itself. So vaginal versus C-section, is one preferred versus the other? When do you decide to do an assisted vaginal delivery? So perhaps hear a little more about pregnancy heart team monthly meetings, and then we can transition to decisions about the delivery itself.
Yeah, I can certainly start with that. So the monthly meetings are virtual, and really, and again, I say this with many women, most women will do well, right? Most women do very well with a lot of planning. They will do very well. But the monthly meetings are there to facilitate communication and also to ensure that our patients are meeting with everyone that they need to meet with and are really kind of on track to have the safest delivery and outcome possible. And so we can maintain an active list of all of our patients who are pregnant with any cardiac disease. So acquired, congenital, arrhythmia, heart failure, aorta, they're all grouped together. We just have one running list, and we review the patients. And it can be very brief. There's more detailed discussions when there needs to be, if acute events come up, to just, update colleagues, get input from colleagues. So it's a way to, I think, better enable communication across the multiple disciplines, make safer delivery plans. And it's also educational. So we include, fellows from MFM, from cardiology, from anesthesia, because we're all, just like these podcasts, constantly learning from each other, which is, I think, one of the best things about multidisciplinary teams.
I will just interject, they're very, very popular with our MFM fellows.
Yeah, and I know that our fellows really appreciate it as well. That the other thing that's really nice is to also be able to coordinate anticoagulation as well during that time, because that actually affects the type of anesthetic that these patients can have. So, for example, we know that if we give them an epidural for their labor, they're going to have less catecholamines. And so kind of surges during labor itself, and as well as cardiac output swings. And so if the patient comes in and is still on their low molecular weight heparin dosing and the timing isn't quite right when they're in labor, that can actually prevent them or from getting a labor epidural, because we don't want them to get a spinal epidural hematoma. And there's plenty of spinal epidural hematomas that have been documented in the setting of low molecular weight heparin administration. So we follow our American Society of Regional Anesthesia, or ASRA, guidelines very, very closely, which is typically for most patients 24 hours after their last dose. So,
Carl, I'm wondering if you could explain when we start, like, for the delivery, just because to set the stage when you talk about like further, like vaginal delivery versus cesarean, what is or an assisted vaginal delivery, like assisted second stage? Like, what does that mean when we say that?
Good question. So typically what that will mean is what we phrase an operative vaginal delivery, which is either a forceps assisted or vacuum assisted vaginal delivery. Most commonly, these are low or outlet. And the rationale is to reduce the amount of time that a mother is actually pushing or actively valsalvating during the second stage of labor. So we're expediting delivery to reduce that window of time.
A follow-up question to that, at least in my experience, and you can all agree or disagree. For our cardiac patients, we generally prefer vaginal delivery. However, there's probably a subset of individuals where C-section is actually indicated for cardiac reasons. Certainly there are the obstetric reasons for C-section. Could you share a little more on your perspective on that?
I would agree with you, Dr. Sweet. Seldom is a cardiac condition an intrinsic rationale for cesarean section. But I would add an asterisk there and say in our mothers who require intensive resources that must be coordinated at a specific time, those situations for logistical planning purposes, perhaps it is wiser in those cases. If we have mothers who are on warfarin anticoagulation for mechanical valves, in those situations, we can reverse the maternal anticoagulation. However, the fetal anticoagulation may persist for several weeks, and as a consequence, those moms are not truly candidates for vaginal delivery due to concern for a fetal intracranial hemorrhage.
So there's also significant anesthesia implications, obstetric anesthesia implications, depending upon how Carl chooses for a particular patient to deliver. So for example, if he's going to delay that second stage of labor, that baby's going to labor down and really put a lot of pressure on that perineum. So epidurals provide really excellent labor analgesia during first stage of labor. But as the baby begins to descend down, we experience a phenomenon that we call sacral sparing. So essentially, the epidural is up in the lumbar spine. We're spreading local anesthetics against those lumbar nerve roots, but it doesn't spread or soak in on those thick, remote, thick sacral nerve roots. And so when I know that he wants a delayed, sacral sparing, I want to put that epidural a little lower and I want to run it a little higher. And I also typically do a dural puncture epidural technique where I put a tiny hole in the dura in order to try to get that local anesthetic right on those nerve roots across that dura into the CSF itself. And that can try to help prevent sacral sparing, but sometimes it's really hard. Sometimes you got to replace your epidural and with what we call a combined spinal epidural during that time. And so, that delayed sacral sparing can be trickier than it seems to keep them comfortable during that time.
And Katie, are there any particular cardiovascular diseases where you look at the patient and you're like, oh, wow, this obstetric anesthesia is going to be a little more challenging, or perhaps the patient will be at greater risk or require invasive monitoring? Like, what patients are those from the cardiovascular perspective?
So Cardio-B obviously covers like a very vast spectrum of patients. And so there's kind of from each bucket, you're kind of really high risk patient. So a lot of these, if we think about it, are modified WHO class 3 to 4 patients. Those are the ones where, all of our, your radar is up a little bit more, and we're really making sure we're having a solid, really very, very safe plan. And so valve stenosis comes up. So aortic and mitral valve stenosis, significant obstruction. So, someone who's, hyperdynamic, hypertrophic cardiomyopathy with a lot of obstruction. Unstable heart failure, we kind of mentioned that one. So someone who's decompensated or, volume overloaded and, requiring oxygen, diuretics, and that. Other ones would be, even just recently, we had a patient with an aorta that's kind of increasing more than expected and a little unstable through the pregnancy. And so those are patients. That was actually a reason why one of the cardiac reasons we think about cesarean section. But sometimes those aorta patients are also ones that there has to be some careful decision making about. And then arrhythmias too. So I think that if a woman goes into SVT or, NSVT or something during the labor and delivery, which is certainly possible, I think anesthesia is really often one of the first people there. And so that's a lot, Katie. Sorry.
Yeah, no, it's good. So I kind of think of obstetric anesthesia as a little bit of a sport. You got to go to where the puck's going to be in the future and not where it is. So the help from Dr. Katie Young to be able to, help us predict where that's going to be is super important. But the ones that I see that I think that I get most nervous about ahead of time would definitely be the patients that are in that MHU class 4. So, and the things that are similar about those hemodynamically is that they spiral. And so, for an example, Katie Young talked about the fact that she gets concerned about valve stenosis. So let's take an aortic valve stenosis, and you've got your thickened myocardium that has been pumping against that thickened valve. And then there are a gazillion things that cause diastolic blood pressure to drop during a labor and delivery. I set up a spinal, I do an epidural, the patient bleeds a bit, she gets terbutaline, like a gazillion things can happen that cause that blood pressure drop. Blood pressure drops. What happens next? Well, the coronary perfusion goes down to that thickened myocardium. What happens next? The myocardium gets a bit ischemic. What happens next? The cardiac output decreases. What happens next? The blood pressure falls further. What happens next? And we've spiraled, right? So now you're spiral. So what's your exit strategy to that? Get that diastolic blood pressure up. I exit a spiral of death from aortic stenosis with a little bit of phenylephrine or a lot of phenylephrine, right? So I got to get that pressure up, get that coronary perfusion. And that's how I think about every one of my lesions. How does it spiral and how do I escape the spiral? And I'm ready to go with that. And so, so for that is an example. The next type of thing that I do not like it at all is when you combine preeclampsia or a hypertensive disorder of pregnancy, right? So that diffuse generalized endothelial dysfunction, and you combine that with heart disease. As an anesthesiologist, I am not happy. Why? Well, for any intervention that we do in preeclampsia, you're very concerned about a hyperdynamic, hypertensive response that results in stroke. And then from the cardiovascular standpoint, we're extremely concerned about anything that drops the bottom out of our blood pressure because we'll spiral quickly. So it's like you're in this Goldilocks where you can't get them hypertensive, you can't get them hypotensive. So as you induce anesthesia, as you start, everything is so careful. So everything has to happen slow. You really want to get your arterial line in, make sure it works, get your beat to beat blood pressures, have your things that bring your blood pressure up, the things that bring your blood pressure down right there at your fingertips. And you are just on it because any little sort of deviation can really hurt the patient. And then the third thing that I just don't like is when Carl, one of your obstetric emergencies, starts messing along with one of Katie's cardiovascular diseases. And then now we're bleeding. So if you give like a patient with placenta accreta spectrum plus significant valvular disease, forget about it. Like, I'm like, oh, great. Like, this is going to be a good day. So we got to make sure we got all our monitoring there. We got to make sure we got blood in the room. We got to have all our pressors, the things that bring our blood pressure up, and all of our clofidipine and things that we like to bring our blood pressure down in there, in line. That's when we start talking. All these cases are the cases we start talking about. We're putting invasive lines in. We're making sure that all of our monitors are working really well. We've got our 5-lead EKG, and that I'm working very, very closely with things start to tip a little bit one way or another. They're well diuresed. We're not starting an induction of labor until their lungs are dry. All that stuff is really, really careful. So those are the ones that I try to get to where the puck is going to be and not getting scored on, right? Because we've all been in situations where we get behind, and it's not a good feeling at all for these patients.
Carl, any comments that you'd like to add?
No, I'd say one of the other maybe scenarios that we see not terribly frequently, but frequently enough, are the pulmonary hypertensives, and those are very challenging, and that is truly a multidisciplinary approach in those cases. And commonly in those situations, we also may suggest cesarean section, again, just for having resource availability on an urgent or emergent basis if needed.
To all of you, I mean, we could talk for a long time because this is just so informative, and I always learn whenever I talk to any of you, but having you all together in one location to have this discussion is just phenomenal. We should wrap up. So any final words? I guess I'll start with Dr. Katie Young and then Dr. Katie Arendt and Dr. Carl Rose. Maybe each of you can kind of give a final comment or a word of advice for our listeners before we say goodbye.
Thanks so much, Marysia. So this is, so first off, And I think I've had a very similar theme for all of these, but I think the biggest take home is that every woman's plan, every patient's plan really will be a little different. So it's hard to give, recommendations that are going to match each person because everything really needs to be individualized. And so everything might look slightly different based on the condition, based on that mom, based on their preferences, etc. And so really just encouraging everyone to find their team like we have.
From my perspective, from the perspective of me as an anesthesiologist, I always like to remember what a team sport OB anesthesia for patients with cardiovascular diseases. It's the ultimate team sport, right? Stay humble, stay open, stay on your toes. But the other thing is that for the patient, this is still their birth experience, right? So even though the feet of our duck are kind of like moving, and we're talking in front of them, we still need to give them this super smooth experience where they really feel safe and secure. They are delivering at the Mayo Clinic. They are safe. We've got every resource in the world that we could call on. We've got tons of expertise. Providing them with that reassurance so that they get the experience of that security on this really, really special day for them as they begin the life of their newborn. That we never want to lose sight of that. Even when inside we are feeling a little stressed at times, never show it.
I guess I would probably, to follow would be, we try for every patient to go into labor and delivery with a game plan. And that might be plan A, which might rapidly become plan B, et cetera. And I think the other thing that I would add is that what's really crucial and probably has been sort of enunciated and maybe even implied is that communication in these situations is key. Just working with one's colleagues and really communicating well, both before, during, and after.
Excellent advice from all of you. And thank you again for joining me to discuss this topic. And I wish you all good night. Thank you all for listening.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.